focus பண்றேங்க.
Good evening, sir. Dean, sir. Shall we start, sir?
So, Murali?
Yes, sir.
We shall start.
Yes, sir. Please, sir.
How
sir,
many
as
of
of
them
now, 28, sir.
And
audience sir, கொஞ்சம் பேர் வந்திருக்காங்க சார். I mean online sir.
Offline
direct இருக்காங்க சார் ஆடிட்டோரியம்ல சார்.
நம்ம ஸ்டூடண்ட்ஸ்
இன்னும் வரலைங்க சார். இன்னைக்கு ஏதோ ஆஃப் டேன்ற மாதிரி சொல்லியிருந்தாங்க சார் காலேஜ். வர சொல்லியிருக்கோம் சார், வந்துடுவாங்க சார்.
அது ஹாஸ்டல்ல இருந்து வர சொன்னா வந்து.
ஆமாங்க சார், சொல்லியிருக்கோம் சார், வந்துடுவாங்க சார்.
We can start.
Sure sir, please sir.
Good evening all the consultants, doctors, postgraduate students and allied health college students. We all welcome you on behalf of our Sri Ramakrishna Hospital Management to this webinar, which is one of the series of webinars we are conducting for the last 3 years now. And now it has become a bi-monthly webinar, and it has become a hybrid variety. We are conducting both offline and for the benefit of our students, postgraduates, and our own consultants, and for the benefit of consultants and general practitioners within city, online also. Today's speakers are Dr. Siddhartha Buttavarapu, MD Pediatrics and Fellowship in Neonatal Perinatal Medicine from University of Calgary, Canada. He is a senior consultant neonatologist and HOD of our pediatrics department, Sri Ramakrishna Hospital. And Dr. Suja Mariam, MD Pediatrics and DM Neonatology. She is a consultant neonatologist in our hospital. And after they have joined Ramakrishna Hospital, our neonatology department has tremendously improved and has become one of the best departments in the city. And we have a lot of referrals from the 4 districts of, surrounding Coimbatore, and also from far off places. And now it is number 1 center, referral center for this region. And Dr. Siddhartha is going to talk about improving outcomes in extremely preterm infants. Improving outcomes in extremely preterm infants, which is a very useful topic and a common problem encountered in our practice. And Dr. Suja Mariam is going to talk about perinatal asphyxia implication, prevention and treatment. Perinatal asphyxia, implication, prevention and treatment. That's also a common problem encountered in our neonatology practice. And both have mastered their own, the subjects in their own field. And now I would call upon Dr. Siddhartha to deliver his lecture. Thank you.
So maybe
Good afternoon, everyone. Hope I'm audible and the screen, slides are visible on your screen.
Yes, sir. You are audible and your slides also visible, sir. Please continue, sir.
Thank you. So first topic for today, we're going to talk on improving outcomes in extremely preterm infants. So we are a tertiary referral center for all the small preterm babies. And this month is Prematurity Day. We celebrated on November 17th. So we thought this is a timely topic to talk about preterms. And among preterms, because we have so many different categories, the smallest, that is less than 28 weeks and less, is the major challenge now. Because with the improving NICU care, outcomes in the rest of the population, more than 28 weeks, are now quite a cakewalk. So we want to talk about how to do better with extremely preterms. Okay. It's a slightly exhaustive topic. I'll try to do as much as possible in the 30 minutes. Okay. Okay. So about 10 to 15% of all babies are born before they are due. So that means they are not ready to be born. And that's about 15 million of them each year. And about 60%. So the major chunk is born in South Asia and Africa. So India handles most of the preterm births in the world. So the challenge is because in the third trimester, there's rapid growth of the baby. Also, there's a developmental maturation, and these things are interrupted as soon as the baby is born. What we want to do in NICU is to at least try and restore this a good environment for the baby to develop as similar to what they would do in utero. So extremely preterm, as I have already said, are born at less than 28 weeks, and about 0.5% of all live births are in this category. So if we look at how the survival in these babies has changed over the years, we can see laser gun pointer. We can see that the smallest babies, which is the last line in this slide, about 22, 23 weeks, the survival is still about 40%. And it was 20 to 25 like 10 years back, 10, 15 years back. Whereas from 24 weeks, the survival has nicely improved. And now about 26, 27, our survivals are close to 90%. So the time trends, this is from UK data from 2008 to 2015. There is definitely improved survival with the latest care. What happens to their outcomes? See, all this survival should not translate into a morbidity for the society. We want to give society a good, healthy preterm with with normal brain and development. So what is happening with these outcomes? This is a Dutch study, which is quite recent, between 2018 to 2020. Neurodevelopmental impairment, NDI stands for neurodevelopmental impairment. Free survival is about 50% in 24 weekers, born at 24 weeks, and climbs up to 2/3 in 25 weekers and 75% 26, and about 27 to 28 they are pretty good, 90%. So this is the latest recent outcome from a Western country. And our data from our hospital, we don't have a long-term data, but this year's less than 29 weeks, we have had 38 babies. We had 2 deaths, so that survival is 95%. The deaths are from a 23 weeks, 1 baby, and 1 baby died is an outborn. It came to us at 26 weeks, died with necrotizing enterocolitis. So survival rates are pretty good, pretty comparable to Western data. So our challenge is in India to improve the survival further, to convert the 24, 25 weeker survival to little higher rates, and then not to convert the survival into socio-economic burden for the family as well as the society. So how, just going about the talk outline, we'll have antenatal interventions to improve outcomes, delivery room and NICU interventions, where we'll see how to protect the lung, brain protection, infection control, and developmentally supportive care. We'll primarily focus on lung and brain protection and a little bit about the development supportive care, because all of these are individual talks and we won't be able to cover these in detail now. So antenatal interventions, and the most important antenatal intervention is, we cannot predict or prevent preterm birth completely. But recently, we can have the latest technology. There might be some clues coming up where they can predict preterm births, and in those conditions, they can do a cervical encerclage or progesterone treatments and expectant management of PPROM. So all these can lead to delaying preterm birth, and that is one antenatal intervention. The second is, this is most important, is delivery in a center where level 3 care is available. That's the higher NICU care is available, where they can ventilate these babies if required and do a proper care. So what they have seen is odds ratio of mortality in these babies is 3 times if they are outborn compared to when they are inborn. So the first primary intervention to improve outcomes is to refer these babies in utero and deliver them in a center with good NICUs. Second and most effective intervention is an antenatal corticosteroid. Okay, more than what we do in the NICU. If there is time, for all obstetricians who are handling these small babies, there is an impending risk of preterm delivery, make sure that they get at least the full dose of antenatal corticosteroids. So either dexamethasone, which is given 12th early, or betamethasone once a day for 2 days. So these you can give, and that will help in promoting maturation of the lung, increasing surfactant production, increases the stability of the basement membrane, So reduces HMD, reduces interventricular hemorrhage, decreases mortality by a significant proportion. So this is a very important intervention. Even if there is no time left, give one dose and that will help the baby. Okay, the best time for this is 48 hours after the 24 hours after the second dose till about a week after the second dose. The steroids work well. So if the delivery has not happened and the patient is still in baby is still in utero, a repeat dose can be given. If there's again any impending preterm delivery, only one single rescue dose if the time interval has exceeded more than 7 days and if the gestation is less than 33 weeks. So there's one word of caution. We have actually gone from underutilizing antenatal corticosteroids to slightly overused nowadays. So particularly in late preterms and in term babies who are taking up for elective cesarean section, there's a word of caution. There's a latest article from JAMA which is saying there is probably a higher risk of neurobehavioral disorders in these babies, especially if steroids are given to term patients, term babies. So definite benefit for extreme preterms and very preterms. Beyond that, be careful. Maybe one course is okay for late preterm deliveries, but not for term. The other antenatal intervention is tocolysis, that is to giving uterine relaxant medicines. So either nifedipine or you can use etosiban, which is an oxytocin antagonist. These ones are preferred. We should avoid indomethacin because it can close the PDA in utero and that can cause pulmonary hypertension. So tocolysis can be used to buy time, so at least 48 hours. So you give tocolysis and give the antenatal corticosteroids. So that is recommended even when there is PPROM and choreo, especially in extreme preterms. So intrapartum MagSulf is the other antenatal intervention. Here, a significant neuroprotective effect. If you give MagSulf to mother, it helps with causing less injury to the brain for the preterm baby. This protection is over and above the protection afforded by the steroids. So if possible, please give MagSulf also, and the dose is 4 grams loading and 1 gram per hour infusion for 12 to 24 hours, especially in all less than 32 weeks. It decreases. There is a number of studies now that shows that decrease in cerebral palsy and the OR ratio is quite good. So if you treat 67, we'll prevent 1 CP, and that's a pretty good number. And it does not cause any significant adverse effects for both mother and baby. So that's about the antenatal interventions. Coming to what we should do in delivery room. Mainly first, make it more effective, right? More effective, more efficient. There should be no chaos. So if the resuscitation is not going smoothly, not orderly, then we will not achieve the goal of resuscitating a baby smoothly. So that's number one. So make it more efficient. We should use a few things. And one of the most important things is to use a checklist. These checklists were initially used in airline industries to get Sigma 0. We got it from the airline. So here it's ideal for resuscitation setups. So we'll ensure that the equipment is present, the equipment is working, the staff are all oriented to what they're going to do. It helps in decreasing communication errors. So all these are improved with use of checklists. And also if we have simulation training, like resuscitation, you can do video debriefing, record you do some mock drills, record them, do simulation, show it to people who are engaged in resuscitation. That will help improve their resuscitation skills. So this is all research proven actually. So these things will help with better delivery room management of these small ones. Because when they're so tiny, all of us are scared, tensed, anxious. So unless we do this many number of times, we won't get the rhythm right. So we'll end up having a lot of errors otherwise. So checklists, mock codes, drills, simulation training are a must to improve delivery room management. This is just a sample checklist where each person in the delivery room has a particular set of work to do, so that prior itself, what your work, what your role is. and help with better delivery. So the other major delivery room management is to protect the immature, small, developing lung from injury, right? So that's our mantra is CPAP. To reduce all the injury, we use CPAP for all these babies. So if you can see, this is the slide showing lung development. And if you see the saccular stage, that's where all our preterm babies are born. So saccular stage is where still the alveolus is not fully developed. They have only got alveolar ducts and a small sac out pouches where there is some gas exchange happening, but they are not ready for life yet. So this is where we need to help them because their lung is not fully developed. Not just help, we should be making sure that we are not doing any damage to these lungs. So if you see the cutoff between canalicula stage and saccular, it's around 24 weeks. So that's the stage where it is periviable stage. Whether these babies 23, 24 can survive or not, it depends on whether they are able to have a good lung, at least a little baseline good lung, which can be helped with treatment. One concept here is called functional residual capacity, where see all of us will breathe at functional residual capacity. That is, there is some air left in the lung at the end of each expiration. At the top of this expiration only, we all breathe. Our normal inspiration expiration happens. These small babies, preterm babies, do not have FRC by themselves, because FRC is generated by our breathing effort, our lung, our muscles, surfactant in the lung. Okay, so all these are not present in the preterm, so they do not have FRC. So if you do not have FRC, it's like the balloon analogy, right? The first balloon is fully collapsed, so that shows that they have no expiration, post-expiration air. The second one is slightly inflated, which means it is at FRC. So imagine a balloon that you're trying to blow, which is fully collapsed. You take more effort to open that compared to something that which is already slightly open. So that is the role of FRC. And what we do at resuscitation is try to generate FRC in these babies by treatment. Okay. The challenge is generating without injuring the lung. Because if you injure the lung, they develop bronchopulmonary dysplasia, which is a long-term chronic lung condition, and they can need respiratory support for several weeks or sometimes months. So what they have seen with CPAP is if you start CPAP early at birth, it helps in generation of FRC, even without giving exogenous surfactant. So it's quite safe, feasible. Now it's become standard of care to use CPAP at delivery for all these ones. So the evidence shows that there is less volume trauma, less atelective trauma, less inflammation of the lung, less deaths, and less BPD. All this is achieved with a simple intervention of using CPAP at birth, which is delivered by using something called a Neopov, so or a TP resuscitator. These TP resuscitators are nothing but manual ventilators, which will generate set PIP and PEEP. And if you have set pressures, you're not increasing the risk of injury with high pressures. So what all equipment is required for these babies at birth? Definitely we need a Neopov. That's a T-piece. Second, we need oxygen blender, because oxygen is injurious, harmful to all growing organs. So you don't want to give more than what is needed, right? So definitely a blender, and we start resuscitation with FiO2 of 21 to 30%, not more than that. And then you titrate according to the saturation levels, whether we need to increase that oxygen. We need a 00 blade for intubation in case it is required. So if we are doing extreme preterms, make sure you have a 00 blade in your unit. 2.5 size ET tubes. Less than that is not required because it increases resistance a lot. And obviously ET securing tapes, which are skin friendly. And then we need a trained team which handles these babies on a regular basis. Then the outcomes are definitely better than somebody who is doing it for the first time. And we also need to have surfactant warm to room temperature. The other important thing that we should start right from delivery room is skin care of these babies. So plastic wrap so that we have less insensible loss, water loss. So wrap these babies as soon as they're born in food grade plastic, so that reduces water loss through the skin. And all the tapes that is used to attach the ET tube, the orogastric tube, everything should be skin friendly. Either use silicone or a hydrocolloid dressing like Deodam, and then on top of Deodam you can use your Dynaplast to secure these things. Otherwise their skin will peel off and they can have long-term, lifelong scars also. And that's also an IDS for infection if you have a skin injury. Then the other things that we do at birth is, even in these small ones, we should try and do natural cord clamping. Do not immediately cord clamp if the baby is breathing well, and at least 30 to 60 seconds of cord clamping is advised. So that helps with stabilizing hemodynamics, their hemoglobin levels, preventing of transfusions, etc. So definitely delayed cord clamping should be practiced at birth if they are not apneic. Primary CPAP, as I've told you, we should start. Prophylactic surfactant. We used to give surfactant to all these babies right at birth, intubate them as soon as they're born and give surfactant. But right now that whole theory has changed. The practice now is to give primary CPAP to all spontaneously breathing preterm babies, even as small as 24 weeks. After once these babies are stabilized, move them to NICU. And then if the oxygen requirement is less than 60%, we should try to get an X-ray prior to giving surfactant to these babies. So continuing the same lung protection in the NICU, we should continue with this called open lung policy, where you have CPAP trying to open the alveolus, keeping them at FRC is called open lung. So even in the NICU, the same thing is followed. They are put on bubble CPAP, where it helps keeping the lung at FRC. But if the bubble CPAP is not working, that means their oxygen requirement is high, more than 30%, or their CO2 levels are high, or there's severe work of breathing, we need to intubate them and give surfactant if required. And again, the ventilation here is the mode of ventilation that we use in these small babies is volume controlled, not pressure control. I think in adults and all they do volume only, but the same technology to come to newborns took some time because they have to measure that such small volumes. So for instance, there is a 1 kg baby, you need volumes to be delivered as 4 ml. And if it's a 500 gram, it's only 2 ml. So the software algorithms have to be very precise to calculate that much volume to be delivered. So right now we have good ventilators and we do volume control in our unit as well. This helps in preventing babies getting into hyperinflation, their CO2 is going too low. If the CO2 goes too low, their cerebral blood flows become very high and then it varies. So that can cause interventricular hemorrhage. So this is an important step in preventing neuro injury as well as lung injury. And so we do volume control as much as possible in these ones. So the recommended tidal volume that we use is we start with 4, we go up to 5.5, very rarely 6. And then if they are intubated, we should try and extubate these babies as soon as possible. But there is a caveat here. If they are tiny, like the 24, 25 weeks, if you are extubating them, make sure they are going to stay extubated. Reintubation within 72 hours also has shown that these babies can have a negative outcome. So there should be a standard extubation criteria that these people should meet before we try and extubate them. Also, there should be a standard ventilation associated pneumonia prevention protocol that should be followed rigorously in the unit to prevent any kind of infection to these ventilated babies. So for instance, they should be on, the head end should be elevated. They should have a closed ET suction in place. Suction only if required, not routinely. And early extubation, as soon as they're ready, they should be extubated, right? And obviously hand washing is there for all kind of infection control. The other drug that helps in these babies is caffeine. Caffeine is just a coffee, but for all these small ones, this is lifesaver. So caffeine helps babies breathe. Babies often forget to breathe by themselves. So if you give caffeine, it's a respiratory stimulant. So it tells the brain to take a breath. Not just that, it also helps improve the lung dynamics as well. It's a bronchodilator. It helps with muscle, better contraction of the respiratory muscles. So it has numerous benefits. So we have to start caffeine prophylactically for all babies who are less than 30 weeks, and these extreme preterms definitely, right? And caffeine is also shown to reduce the long-term effect of chronic lung disease in these babies, and also helps with better neurodevelopment at a later stage. So important drug. Also, we have seen that, if you give CPAP for a few weeks after birth, it helps grow the baby's lungs well, because when they are inside the mother, the lung is filled with amniotic fluid. That distension helps with lung growth. Once they are out, there is no fluid, there's no distension, the lung will not grow as well. So if you put CPAP, there is some distending pressure continuously. It is similar to what fluid will do. So we try to keep it in these small babies at least for 4 weeks. So for them to grow their lungs better and prevent, again, bronchopulmonary disease. That's about the lung part. Coming to the brain. So these two are major important that we deal in preterms. So in the brain, again, one is the neuroprotective care, and we can divide it into something called developmentally supportive care. So neuroprotective care, you can see the slide where how the brain is affected in all preterms. Antenatally, the mother can have infection, or there is placental insufficiency, there's less oxygen going to the baby. This can cause cell death, oxidative stress, inflammation in the baby's brain. Preterm birth by itself, reduced antioxidant activity. There are fragile vessels, so this can lead to bleeding. Bleeding happens in areas called germinal matrix, which is an important center for generation of brain cells. So important brain cells are produced from there. So bleeding there can have devastating effects. So we want to prevent that also. Postnatal factors. If you are doing ventilation to baby, if you are doing, giving postnatal corticosteroids, there is sepsis, meningitis, all these can cause effects on the brain, right? But importantly, in the first 72 hours, it's crucial because brain is at the most vulnerable stage here. So we want to protect the brain at this time in a number of interventions. But the problem here is in the first 72 hours only, there's a lot of things going on with the baby as well. Right? The baby is being intubated or put central lines. There is number of pokes for blood work, sugar checking, gas checking. So the baby is handled actually on an average 110 times a day for all these extreme preterms. So much handling happens, babies get stressed. Every stress is a risk for the brain, because stress changes hemodynamics as well. Flows to the brain will change. So our focus is we have to be intensive, at the same time try to be gentle. Gentle care, gentle handling, try to minimize our handling, give space for the baby to recover between these handlings, and then accepting a little bit of higher CO2 levels. Okay, because if we keep driving the CO2 down and down, we want to keep it between 35 to 45. You keep doing more and more to the baby, that will again cause more stress, change in flows. So now our targets are between 45 to 55 for CO2. That's called permissive hypercapnia. So there is a study where they have done something called neuroprotection care bundle. There are a few things, they have put it in a bundle. Now this is the major thing in ICUs. I think everything is clubbed together, a few interventions clubbed together and called bundled. So here neuroprotection care bundle is, again, they have tried this and they have shown some outcomes. So what does that have? Maintain temperature. So for the baby, for any newborn, keeping them at normal temperature is very important. Here, first thing is maintain euthermia. If it's low, make sure it comes to normal by checking every 15 minutes. Hyperthermia is actually more, it can cause even more damage to the brain. So avoid skin trauma. Again, pain, trauma have to be avoided. So I have already told you, use hydrogel electrodes, deoderm and silicone tapes. You can try to remove adhesives very gently. If it's not possible to remove, just leave them on. If you pull them, then again that's a problem. Then minimize the handling that we have already seen. We should try to establish vascular access within 30 minutes and start nutrition. If there is total parenteral nutrition started early, that helps with preventing catabolism of the baby, right? So that helps with bodybuilding. Bodybuilding has to happen for the baby to grow and develop properly. So starting TPN early is also one neuroprotection intervention. How to position the baby? Maintain the neutral neck position. So this is a very simple intervention. If the neck is turned to one side and the baby is in the early parts, it can cause 30% increase in blood flow to the brain because it compresses the veins on one side. So that can cause IVH. So in these small ones. So maintaining stable midline position is very important. Keep the head elevated for 30 degrees. And in these babies, at least up to 72 hours, do not do prone pose. Okay. Permissive hypercapnia, we have already said 45 to 55 to avoid abrupt flow changes to the brain. And CPAP, when we are doing, make sure the nose is not getting injured. That's a huge science and a huge topic, but the CPAP skin should be protected properly. Hypotension, again, this one is a major, what do you do if the BPs are low for this baby? Or how to prevent this hypotension from happening. So what we see is if you do DCC and there's a lot of blood coming in, some extra blood, so babies are more stable hemodynamically. So that is the practice is we should do delayed cord clamping and try to avoid inotropes. Whoever is getting inotropes early on have a, they are more, obviously they are sicker, but if you give unnecessary inotropes, it is also a risk factor for bad neurodevelopmental outcome. So before starting inotropes, we should make sure that the baby's perfusions and the end tissue perfusion is actually okay. So even if the BP is low, if the oxygen trends are fine, baby's perfusion is fine, pulses look good to you, there's good urine output, the lactates are normal, there is no metabolic acidosis, maybe we can wait for starting inotropes. Before starting inotropes, try to give some fluid, see if the babies will respond to fluid, but fluid has to be given very slowly, around 30 minutes, not like the other population groups where we give it fast. So saline bolus has to be given only over 30 minutes. So we can consider inotropes if we lactate, CRT is more, lactate is more, urine output is less, low cardiac output on echo. At least 2 out of 4 of these are present, then maybe we can think of inotropes. So don't jump onto giving inotropes is the message here. Try to see if the perfusion is fine and if baby will respond to fluid. And if there is a hemodynamically significant PDA, we have to treat in this extremely preterm babies. So there's a lot of controversy. So the current recommendation is to treat. So this, they have done this study in Canada, and they have seen that their brain injury, which they have classified as is the grade 3 or grade 4 IVH and periventricular hemorrhagic infarct, had decreased from 25 to 30% to around stabilized around 7% after this starting the bundle. So that's a huge improvement in outcomes with just a simple neuroprotection care bundle. Okay. In our NICU this year, I think we have had 2 major bleeds. One was a grade 3 IVH, one was a grade 4 IVH, and one was in 24 weeks and one is a 26 weeker. Otherwise, the rest of the 36 babies had only small bleeds. So that pretty good we are doing with neuroprotection. Developmentally supportive care is the other part of protecting brain here. See here, the typical busy NICU will look like this, where there's lots of tubes, a lot of people working around, and a lot of equipment, and the baby you can miss because it's going to be only half kg there. So developmental supportive care is the strategy that we develop to minimize stress for baby and to promote good normal brain and normal development. Okay, just basically that is it. I'll just jump through this. Why should we do? Because the preterm infant's brain is very immature. It's easily affected by external stimuli. All forms of sensory input to the immature brain influence long-term development. So we don't think that the monitor is keeping on alarming. If the baby is a preterm, please go and stop it as soon as possible. Because these are small stuff, like there's a bright light there, it'll affect the baby. If you're shouting near the baby, it'll affect the baby. Not just at that point, there's a possibility that those things do have a long-term effect as well. So that is the difficulty of doing NICU care, is that even though when you're doing intensive care, you must take into account the development of the baby as well, right? And all this stress can cause loss of sleep for the baby. If the baby is not sleeping, brain is not going to mature properly. And not just this, future long-term sleep, like when they are 3 years old, 4 years old, also can be disturbed because of what we do in the NICU. What are the components of developmental care? Lighting. So facilities to dim lighting or cycle lighting should be there in the NICU, where in the night there should be slightly dimmer light so that the circadian rhythm is stimulated and their sleep patterns get better. Noise level should be kept at less than 45 decibels. That's just less than a whisper. So if you're doing major interventions here, should be shut the door slowly, opening the incubator door slowly, not talking loudly, doing rounds away from the babies. So all these are noise interventions, okay? And using quiet hour. We tried for some time in our NICU to make a quiet hour that where nobody speaks. So to reinforce the idea that noise is bad, okay? But not all sound is bad. Mothers, parents talking to babies, they're singing, music, all these are good positive influences on the baby, and we should try to do them. Some NICUs have live music as well, where they play violin, piano. So that helps. We have seen that behavioral, physiological stability for baby happens, okay? The other component is to promote touch, because the touch is the most developed sensation in the preterm babies. We want to promote, and it gives a sense of comfort and security to them. So how do we promote this, develop this touch sense? Kangaroo mother care or kangaroo father care, where the baby is kept without clothes directly onto mother or father on the chest. And that has shown has many, many benefits. Like babies are physiologically stable, they gain better weight, fight infections better, less apneas, and they go home better. So that's the major developmental care is kangaroo care. Second is called gentle touch or tucking touch, where one hand is placed on the baby's head, one hand on the bottom of the legs. So just holding like that also helps them decrease stress for them. So in between procedures, you can do tucking, you can do gentle human touch. So for them to recover and then to do it again, okay? Nesting is the method where we position the babies in the NICU with the help of positioning aids. Because in utero, they are against a firm uterus. They kick the uterus, they are bound by the uterine wall, they're kept flexed state. We try to achieve that position by using these positioning aids in the NICU to keep them flexed so that their limbs are always in touch with a firm surface. So this has number of benefits, and these we do. I will not go into details because we're out of time. So nesting is practiced. And infection control is the last part of our intervention. So this is our mantra to actually have better outcomes. Both short-term, long-term are improved if you don't have infection in these babies. If they get infected, even if you cure them properly, there is still a chance that all the inflammation that you caused because of the infection is going to affect the brain in some way or the other in the long term. So our focus, our aim is, our mission was to always not to get infections in the NICU, okay? So should be modeled to be the most sterile environment. You should have adequate hand wash areas, hand sanitizers everywhere in the NICU, which are easy to access. They should have isolation rooms for any airborne infections with negative pressure. All the nursing staff, doctors who are working in the NICU should be oriented properly to the infection control practice. Cleaning protocols for the NICU should be in place, and they should be done every day. And everybody should be audited whether they are doing properly or not. Systematic audits time to time will help us find out where the lacuna are, and we can improve the infection control. Visiting should be restricted to parents, and if they have any cold, cough, fever, we don't allow them. We should have proper written policies for how to manage, how to prevent ventilator-associated pneumonia, central line infections, and then aseptic non-touch technique. In the protocols, we should have them in the written and trained everybody. Antibiotic stewardship, we don't give antibiotics unless required. and we start with first line drugs, second, third, depending on what culture we get. Sensitivities need to be followed, cultures need to be taken for everybody. So this infection control has to be done rigorously to achieve any good outcome in these small ones, because they absolutely do not have any immunity. Okay. So I think our NICU this year we have done quite well. With 201 catheter days, we didn't have any CLABSI, that is a central line associated bloodstream infections. And out of 180 ventilator days, we didn't have any VAP. So that's a pretty good number. So we hope to continue that this year as well. So this is a wall of hope that we created this year. So just for all our extreme preterms who were born in our NICU and now big. So we just put some pictures for the later generations to have hope, later generations of preterm families who visit NICU to have hope. So that's all I think from our side. From my side, this is the talk. I think. Thank you for the time.
Thank you, Dr. Siddharth, for your excellent and top of the order lecture. And we can have the question and answer session later. Now I would like to call upon Dr. Suja Mariam to deliver her address.
Good afternoon, one and all. It is always a privilege to share and receive information through these webinars. So the second topic for today is about perinatal asphyxia, its implications, management, prevention and treatment. So as we all know, the leading causes of neonatal mortality currently in India is prematurity and low birth weight. So Dr. Siddharth spoke about improving outcomes in these preterm babies. The second leading cause is infections, and the third leading cause is perinatal asphyxia. So perinatal asphyxia, the definition and the pathophysiology has almost remained the same. Any asphyxia refers to a combination of hypoxia, ischemia, metabolic acidosis because of occlusion of umbilical vessels or interference of placental circulation before or during or after birth. So this is where the definition has slightly changed. Earlier, we used to believe that any perinatal or birth asphyxia, which you used to quote, happens during delivery. But now we have understood only in 10% of the cases that the asphyxia happens during birth, and in 90% of the cases, the insult has happened slightly earlier, even before the onset of labor. So that is why in current definition, they have changed it at before or during or after birth. It is still the leading cause of perinatal death and long-term disability in survivors. Till now, we don't have any unanimous definition or consensus on when to label a baby as having perinatal asphyxia. Now, the recent definitions, there are multiple definitions. We have definitions which are used by the American Academy of Pediatrics. We have definitions that is used by the National Neonatology Forum. The first definition, that is a definition based on an Apgar score of less than 7 at 1 minute or 5 minutes, is used by the National Neonatology Forum. But the National Neonatal Perinatal Database, the NNPD, which is used by the Ministry of Health and Family Welfare, it uses gasping or no breathing at 1 minute of life as a definition. So if the baby is not having any spontaneous respiration at 1 minute of life, in India, we label it as perinatal asphyxia. Now, this is a very easy definition so that peripheral health workers can also know when to label a baby as having birth asphyxia. But it is very relaxed definition. For if you go by this definition, almost 10% of these babies who require some resuscitation will be labeled as birth asphyxia. Whereas on the other hand, the American Academy of Pediatrics is very stringent. That is, the baby should not have had a spontaneous respiration, plus you should have a cord bed gas, plus the baby should have evidence of encephalopathy or end organ damage. That is when you can label a baby as having birth asphyxia. They are very strict with their definitions because they want to protect their physicians. If their definitions are stricter, nobody can come back to you saying that their baby has suffered birth asphyxia. But our definitions are slightly easier to enable people identifying the condition. To all practitioners, labeling a baby as having perinatal asphyxia or giving a low Apgar to a baby does not mean that the baby is definitely going to have bad outcome. It means not all babies with low Apgars develop encephalopathy. So there is a event which has happened either antepartum or during labor, that is occlusion of the umbilical vessels or delayed placental circulation. Then you have an evidence of the event, that is when the baby is born, the baby has not cried at all. By labeling a baby as perinatal depression or giving low Apgar to the baby, we just quote the condition of the baby at birth. Then the consequences, which is encephalopathy or organ damage. Even in encephalopathy, we have babies with mild, moderate, and severe encephalopathy. Okay, so not all babies with low Apgars are going to develop encephalopathy and long-term problems. So when we go by the definition, incidence of perinatal asphyxia, we saw that we have different definition. Every hospital is going to use their own definition. So based on that, the incidence varies from 0.5 to 8.5%. According to NNPD, 8.5% of our babies require some resuscitation at birth. Now, even after the development in obstetrics, there is still, we have see cases where the babies require resuscitation at birth. This is because there is an increase in maternal obstetric illnesses. Today, the leading cause of perinatal depression is gestational diabetes mellitus or hypertensive disorders in pregnancy. The associated factors are mother being dehydrated during labor or she having anemia. All these conditions are quite common in our scenario. Placental abruptions and cord prolapse are reasons for acute asphyxia. Fetal growth restrictions and other rare causes are fetal malformations, systemic illnesses, polyhydramnios, and multiple births. Now we can see the first four more common causes quoted are quite common. Almost 90% of the mothers will fall into either one of the categories. Pathophysiology. I don't want to go into the detailed pathophysiology, but what I wanted to highlight was that asphyxia, as in adults, in neonates also is a continuing process. It is not a one-time event. There is something called as a primary energy failure, that is absence of blood flow and absence of oxygen to the baby, which has happened either before labor or during the labor process. After this primary energy failure, there is a resolution phase where the end organs try to recuperate themselves. So this period lasts for 6 to 15 hours. Then there is a phase called as a secondary energy failure, where there are inflammatory mediators and secondary cell death or injury which is happening. And then there is something called as a tertiary brain damage. Okay. So this phase is where all the fibrosis and gliosis starts taking place, and there will be delayed myelinations and other features in a child. So when you see a baby who is being born, the baby is either in a primary energy failure or a secondary energy failure. We are not very sure because we don't know when the insult actually happened in utero. The clinical features of a neonate is also happens over a timeline. When you see a baby in the first 12 hours, usually an asphyxiated baby after the initial resuscitation will be irritable, jittery, not sucking properly, continuously crying, hypertonic, tachycardic, and will be having lot of diaphoresis or sweating. In between the 6 to 12 hours, there will be a phase where you will actually believe that the baby is improving or settling down. Between 12 to 24 hours is where when there will be a change in the level of the alertness of the baby. So the baby might develop seizures, the baby might become drowsy, and within 24 to 72 hours is where the maximum clinical features exhibit themselves. The baby might become stuporous, comatose, might require intubation, and might develop all features of raised ICP. After 72 hours, there won't be any secondary worsening, but you will have to rehabilitate the baby from all these illnesses. The baby might be ventilated, he might or might not get extubated. So the neurological events happen over a period of time. This is where referrals get delayed because there will be a period when you think actually the baby is improving and settling, you wait, and in the midnight you see that the baby is developing seizures and becoming comatose. Whereas the cardiac condition, hypoxia affects the heart also. Cardiac dysfunction and hypotension is very evident at birth. The baby might require inotropes at birth also. And renal dysfunction usually is evident only after 72 hours. So when you know the asphyxia, the features of asphyxia, clinical features are progressing, you can expect that by 72 hours, you would have to look for the urine output and the baby might go in for acute renal shutdown. There are a lot of neonatal implications for perinatal asphyxia. 23% of all deaths are due to birth asphyxia. The organs affected, though we are talking about the brain predominantly, the most important organ which is affected is the kidneys. So the babies might have complete renal shutdown or they might just have an acute kidney injury, but there is a fall in the urine output and a rise in the creatinine. Heart is affected where babies will have a lot of metabolic acidosis and hypotension. Liver enzymes might be elevated and the baby might develop cholestasis. Gut injury where there might be feed intolerance, and lung injury is another uncommon, not so uncommon feature of birth asphyxia. So young babies, even a term baby who's asphyxiated might require surfactant to open up the lungs. There are lots and lots of parental implications when it comes to perinatal asphyxia. When in developed countries, when these parents are followed up, even when the babies go home well after perinatal asphyxia, they found out that almost 59% of the mothers and 38% of the fathers develop post-traumatic stress disorders. We have also seen such parents where even if the baby is doing well, they don't want to come back to hospital because coming back to hospital, even for a vaccination, it reminds them of the incidents which happened immediately after delivery. There are lots and lots of financial implications. When we talk about newborns, we are talking about a family who's just getting formed. The parents would have been married for 2 or 3 years. They would have hardly known each other. They would have been getting stabilized financially just then. And then you have a sick baby who needs all intensive care and long-term follow-up. There are a lot of social implications because like the couples, the families are also just getting formed. So there will be a lot of blame game happening when a baby is develops perinatal asphyxia. And ultimately, when there is an unfavorable outcome of pregnancy, it always reduces to inadequate care to delivery. It was a story in olden days when baby did not cry at birth. We used to believe that something has gone wrong in the delivery process. But now with all our improvements in obstetric management, we know that some perinatal asphyxias cannot be prevented. They happen in utero even before the active labor process. There are some interesting studies which looked at how parents feel when a baby is being treated for perinatal asphyxia, when the baby do not cry at birth. The common feelings or emotions that the parents shared were a feeling of being thrown into a chaos. The doctor comes out, they're awaiting a normal crying baby. The doctor comes out and tells them in complicated terms what all the problems happen during delivery and why the baby is sick, which none of them they are in a mood to take in and understand. The NICU environment is quite new to them, and whatever is happening to the baby is very terrifying to them. There is a state of uncertainty because for whatever we tell, when is the MRI will be done? After 3 days. When will we know how the baby is? After 7 days. When will you know whether the baby is normal? Only when the babies grow up. So till the baby is growing up, they never know whether the baby is normal or not. There are a lot of investigations. Baby looks normal, but MRI is abnormal. MRI is normal, but EEG is abnormal. So they find it difficult to understand. What they want to hear is that their baby is normal, but they never get that word from anybody. There is too much hope on treatment. We tell about therapeutic hypothermia. Parents start believing that the baby is going to be normal after the treatment, but it is not the scenario. They feel abandoned because there is no one to talk about their inner fears. There are long-term implications to the family also. Though we have been talking about decrease in cerebral palsy, till now 25% of the cases of cerebral palsy in our country is because of neonatal asphyxia. Developmental delay, and again HIE contributes to 25% of all children with developmental delay. Even the milder cases of asphyxia who required minimal treatment, on follow-up, they are found to have ADHD, attention deficit hyperactivity disorders, and learning difficulties. Now, once we discussed about the implications, let's see how we are going to prevent and treat this perinatal asphyxia. When we come to prevention, we know that there is no absolute cure for asphyxia. We spoke about the stages of asphyxia. but we are just going to watch. We are just going to watch the baby become irritable. We are just going to watch the baby develop seizures. There is no actual treatment. We try a lot of things, but none of it is going to reverse the injury that has happened. For preventing during labor, now whatever is quoted is called as the at-risk approach. So categorize all mothers into low risk and high risk. Provide the utmost care and monitoring for the at-risk mothers. Be prepared for even for the low-risk mothers. There are two important topics during labor that I wanted to highlight here. One is the cardiotopography or the continuous electronic fetal monitoring. Nowadays, we all use the NST machine to continuously monitor the fetal heart rate during active phases of labor. The RCOG and NICE guidelines have looked into it. They actually relaxed the guidelines telling that for low risk pregnancies, you don't have to use continuous fetal monitoring. You can just do a fetoscope and listen to the fetal heart rate. Whereas for all high risk pregnancies, you have to have a CTG at admission, and then you have to continuously monitor the fetal heart rate during the active phase of labor. But they have made a catch there also. This is a list of high risk pregnancies that they have quoted. So all are common conditions: PROM for the more than 24 hours, induction of labor, diabetes mellitus, mothers having any medical problems, oligohydramnios, preterms including late preterm babies, IUGRs, meconium stained lichens, vaginal bleeding, maternal pyrexia, oxytocin augmentation. Almost 90% of our mothers will fall into our category. So the take home will be, if your mother even has one of these high risk pregnancies, it's better to have continuous fetal monitoring or NST during the active phase of labor. If you don't have an NST facility and you want to do good fetal monitoring, it means you're going to have a bedside person who's going to monitor the fetus. The manual auscultation of the fetal heart should be for a full minute after every contraction, and you should be doing it every 15 minutes in the first stage and every 5 minutes in the second stage. If there is any doubt in the fetal heart rate, you think it is less than 110 or more than 160, or you're feeling that there is a deceleration after the contraction, this mother should be put on continuous electronic fetal monitoring. Whenever, in any case of perinatal asphyxia, we go into the medico-legal implications or cases, the most important criticism that the medical practitioners face is that the electronic fetal monitoring print was too short. It was too infrequent. Somebody would have taken as NST, but they would have forgotten to attach it in the file, or there has been a wrong interpretation. So it is very important that we do a proper electronic fetal monitoring and document it too properly, to protect the mother, to protect the baby, and to protect the doctors also. Another important criticism on intrapartum interventions during labor is that decision to delivery time interval. So you have an NST or you have a fetal heart rate which is falling less than 110. You have decided that you are going to deliver the baby. As per guidelines, the decision to delivery interval in cases of emergencies, that means fetal bradycardia or maternal hypotension or something like that, it should be 30 minutes. Even if not, if you have decided to do cesarean section, the time interval should be approximately 75 minutes max. That is, you made the decision, you go out, you talk to the family, get the consent, move the mother, do the spinal, and the baby should be out within 30 minutes in case of category 1 emergency cesarean sections. But on an average, even in developed countries, the best time they are being able to manage is only 43 minutes. This is about the intrapartum management. Now, once you get an asphyxiated baby, what we can do? The post-resuscitation or the resuscitation management. The entire neonatology forum or the neonatology group in India and the world have realized the importance of the golden hour management of neonates. So there has been abundant emphasis which has been put on neonatal resuscitation. Everybody talks about neonatal resuscitations, and it is very important that in any hospital who have an obstetric team, who have delivery rooms, they should have doctors and nurses who are trained at least in basic neonatal resuscitation. So we mean basic neonatal resuscitation when it comes to giving positive pressure ventilation, doing ventilation on a baby, and doing minimal chest compressions alone. Okay. We talk about advanced resuscitation when there is a need for intubation and when there is a need for umbilical venous catheterization and drug administration. So every delivery should be attended by a person who can at least do basic resuscitation, and there should be a person who can be called for advanced resuscitation when required. So now we have the IAP, NNF, and the NRP. IAP is Indian Academy of Pediatrics, the National Neonatology Forum, and the NRP. They have come together with the NRP project. They are doing NRP projects, both basic and advanced, almost in all the level 1 and level 2 cities, almost twice or thrice a year. So we should be looking out for such workshops where our nurses and doctors can get certified. So once a baby has been resuscitated, any child with an ABGAR less than 5 minutes, at 5 minutes less than 4 will require intensive care. Now we here, even if a baby's ABGAR is less than 6 or so, we shift them to intensive care for close monitoring. In NICU, once these babies are brought, we do close hemodynamic monitoring. We have to do blood gases to monitor acidosis. We have to have close urine output and renal function monitoring. We can do lactate levels and creatinine kinase, which is specific for the brain. Blood sugars and the electrolytes have to be monitored. We provide supportive management to all these asphyxiated babies, that is providing thermoneutral environment. That is, the temperature should be between 36.5 to 37.5. We see that the babies are not warmed too much. We provide them intravenous fluids, correction of hyponatremia, hypocalcemia, and hypokalemia, and we provide other supportive care like hemodynamic support, including inotropic support. We don't give routine antibiotics to all asphyxiated babies. Apart from this, now we do brain-oriented approach where all these babies who have mild to moderate encephalopathy or even the severe encephalopathy are put on an amplitude integrated EEG monitoring. We do seizure control and we try to optimize 4 parameters, that is temperature, sugar, sodium, oxygen, and carbon dioxide, which are going to cause the secondary brain injury once the primary injury is over. So we try to maintain all these 4 parameters within the normal levels. Now we have therapeutic hypothermia. In our unit, we have been doing therapeutic hypothermia for the past 1.5 years. We use the critical equipment. We still are not sure whether therapeutic hypothermia is a standard of care in underdeveloped countries, but it is a standard of care in developed countries. It has helped them in it has been effective in reducing morbidity associated with HIE, and in all developed countries, any baby with asphyxia who fits into the criteria has to undergo therapeutic hypothermia. It is a process where a baby is cooled for around 72 hours to a temperature of around 33.5 degrees Celsius and then slowly rewarmed. What happens in therapeutic hypothermia? It suppresses the brain metabolism. It suppresses the activation of the secondary inflammatory mediators, and thereby it decreases a secondary brain injury. It does not reverse the primary brain injury, but it prevents the secondary brain injury. The catch is that it should be started within 6 hours after the baby is born. So this is the critical equipment that we are having. And this is a baby wrap. It is a wrap and a warm saline flows in and cold water flows in to alter the temperature as required. The baby can be wrapped in the critical blanket, and this is the equipment which needs power supply and water. That's all it requires. It is automated, completely automated. So once you know that the baby requires cooling, that the baby is asphyxiated, we can wrap the baby in this critical. You can continue all other ventilation, IV fluids, parenteral nutrition, everything can be continued. This will be an add-on therapy in addition to your supportive management. As I said, the catch is you have to start within 6 hours. So that is where starting treatment becomes problem. I told you that there will be a phase of resolution when you think that the baby is actually improving. So irritable baby, crying baby, it is very difficult to convince parents to tell, no, this baby needs referral or this baby needs higher treatment. Even sometimes physicians keep on waiting for the baby to recover, hoping that the baby will not go into stage 2. But sometimes it happens that you delay treatment, you delay therapeutic hypothermia, but by 12 hours, the baby starts developing seizures and the encephalopathy starts progressing. So any baby who has suspicion, whom you think that they will need therapeutic hypothermia or is asphyxiated, it is better to prime the parents regarding hypothermia. And if you don't have the facility, it is better to refer the parents to a setup which can do therapeutic hypothermia for babies. There are definite clinical benefits even in underdeveloped countries. You treat 11 babies with HIE with therapeutic hypothermia, 1 death will be prevented. You treat 8 babies with HIE with therapeutic hypothermia, 1 child with neurodevelopmental delay will be prevented. So how can we make the situation? We saw that 90% of the birth asphyxias happen antepartum. So how are we going to prevent it? One, create a high-risk approach for pregnancies. Intrapartum monitoring, do and document every steps and measures that has been taken during intrapartum monitoring. Step 3 will be being prepared for emergency cesarean sections. By simulation exercises, by keeping interdepartmental meetings, we have to cut short the time required for emergency cesarean sections. We have to be prepared for intra-hospital and inter-hospital transfer and monitoring of neonates. Improving parental counseling and hospital experience so that they are able to provide follow-up care for the neonates even after the acute treatment is over. And the most important step will be providing optimal post-asphyxial care in NICU. So perinatal asphyxia, we don't know how much we can prevent it, but we can manage it better if we have more resources, training, and information as such. Thank you.
Thank you, Dr. Suja Mariam, for your excellent lecture. And any interaction from the audience, any questions?
Hello, I'm Bhanumati here.
Yeah, please.
It was a very nice lecture from both of the neonatologists. We are also enjoying their services in this institution. Actually, looking at the preterm, early preterm or the gross preterms, we have really saved from the last years. We have follow-up up to so 2-3 years also follow-up is there and good outcome is there, and we are very happy that these things are taken care. And second thing is regarding the perinatal hypoxia, really you have highlighted many of the things, Dr. Suja. One thing I just wanted to tell you is that the CTG is important. As is it, there is some controversy like increased section rate and things are there, but still we are having that CTG support, and we categorize, people are taught to read that, interpret, including the staff nurses. Only thing is, when you have a delivery record, this thermal record, this last half an hour trace should be scanned and then incorporated in the IPK sheet, because this is a thermal graph. It will, after some time, it will vanish. After some time, if the delayed consequences, if they have, the babies have, suppose somebody claims, this will not be, the graph will not be seen. So what we need to do is only the scanning. I request Dean sir to look into this area, that it has to be scanned at the last half an hour CTG, wherever any, irrespective of the mode of delivery, whether fetal distress is there or not, it has to be scanned, and then along with the partograph, it has to be incorporated. Because as mentioned very clearly, antepartum and intrapartum, both the times we can have hypoxia. So antepartum hypoxia detection is still no final word is said. So it is to be followed by the growth pattern and rest of the things. So this was brought out very nicely, because the medical legal implications are very important regarding this, how the maintenance of the record in an obstetric patient, because of the long-term follow-up and the child development, it really matters. And you were mentioning about the a word about neurosonogram, Dr. Suja.
Neurosonogram in birth asphyxia, it is not a gold standard, but when we do a bedside ultrasound for all these babies, it helps us to pick up the worst of the cases, that if you within 24 hours, if you're going to have cerebral edema and basal ganglia changes, it is a poor prognostic factors. We'll be able to pick up bleeds, subgaleal and hemorrhages also, because even therapeutic hypothermia can cause intracranial bleeding. So for documentation prior to initiation of the procedures, we can have cranial ultrasound. Otherwise, currently the gold standard in all these babies is an MRI, which is usually done between day 3 to day 5 after the baby is born. A diffusion weighted imaging is usually done.
Okay.
Thank you, ma'am.
And we have conducted an audit regarding the decision to delivery interval in our institution. We are practically in part, we are happy that it could be done with the proper communication with the anesthetist, theater, and the pediatricians, we were able to do that. Decision to delivery interval was maintained as per the requirement, and so the outcome was good. Thank you.
Thank you, Dr. Bhanumati. Any other questions? From online participants? If there are no more interactions, it is my privilege to thank Dr. Siddharth and Dr. Suja for accepting our invitation to join today, all of us, to deliver fantastic lectures. And I thank on behalf of the management, both of them. And I thank all the participants, senior consultants and doctors and general practitioners, postgraduate students, and allied health college students for participating in this seminar. Thank you, one and all. Thank you.
Sir.
Jennifer Matei.